Ladies and gentlemen, if it's okay, we're going to just wait maybe 3 minutes for the House is finishing up on their last bill so those members can join us. 3 minutes.
Be good.
We voted. Is that a motion? Voting no.
I'll get to the House of Representatives. We do. All right, ladies and gentlemen, we'll get started. The House is still finishing up, but we're going to continue with our hearings, joint hearings with the Senate, and we're very fortunate to have with us businessman, and he doesn't know this, but he's a uniter. Let's have quiet, please. He is a uniter because when I told Senator Bryan about this hearing, I said, I'm going to have a conservative talk show host come speak to us. He said, who is it? I said, Gerard Gibert. And he shook his head, threw his hands up, and said, I might show up. So here he is. Senator Bryan, thank you for showing up. Mr. Gilbert, thank you for loaning us your time and expertise on. Yes, sir.
Just click it on.
Yep. Appreciate that, Representative Creekmore, and thanks so much for having me here today. So, I have been writing, speaking, opining, I guess, on healthcare policy going back to 2008. And that was actually driven by an ad that at the time candidate Barack Obama was running across the nation, a candidate for president, went on to be elected. And in the ad, he was talking about something called shared responsibility. And anybody that is familiar with the Affordable Care Act is somewhat familiar with the shared responsibility. I can assure you that everyone in this room who is an employer with more than 50 employees is intimately familiar, their lawyers are at a minimum, with the shared responsibility. And all that simply meant was that as an employer, the government would expect you not only to provide coverage for your employees, but you also were going to have to cover a significant amount of the cost of premiums. The original idea from the candidate who went on to be president at the time was placed a much greater burden on employers than what we actually got. The Affordable Care Act is passed as somewhat of a diluted, watered-down version of what then candidate Barack Obama wanted, but of course you always go for broke. So that's how I got involved in healthcare. I made a call to my lawyer at the time, who happened to be a guest on my show today, Pepper Crutcher, who is a very skilled labor attorney who represents employers, works on the employer side. And I called him, I said, Pepper, I've been reading about the shared responsibility. I went to Mr. Obama's website and reviewed some of the plans, and I've done the math on this. This is going to cost me a lot of money. And I'm trying to make some business decisions. I need some answers. He said, wait, Gerard. First, this thing's got to pass. He's got to get elected, then it's got to pass, then the Supreme Court has got to uphold it because it's surely to get challenged, then it's got to get codified. I said, all due respect, Pepper, he's going to get elected, it's going to pass, the Supreme Court's going to uphold it, and it's going to get codified. Fast forward now, 14 years later, pretty sure that's what happened. That's exactly what happened. So there was an important provision of the Supreme Court case in 2012 where numerous plaintiffs sought to strike down the individual mandate provision of the Affordable Care Act, which basically said you got to buy insurance, and if you don't, you got to pay a huge fine, significant fine. Well, there was a rather obscure provision in that ruling. And there were a lot of conservatives that were unhappy about that. You remember Justice Roberts, who sided with the left side of the court in upholding the mandate, and that allowed the Affordable Care Act to go on to become permanent law. There was a provision, however, that many don't know about, and that was Medicaid expansion, what's known as Medicaid expansion, which would have extended Medicaid coverage to a new coverage group. First time that had happened since 1965 when the initial Medicaid law was passed, which was initially designated for the elderly of certain low incomes, pregnant women, children, blind, disabled. Able-bodied working adults were not eligible for Medicaid. The Affordable Care Act made them such. Well, the original law said states must expand their Medicaid programs to include this coverage group to remain in traditional Medicaid. And the Supreme Court said, no, you can't do that. And that's exactly why today 40 states have expanded in the United States and 10 have not, of which one is Mississippi. Otherwise, all 50 states would have already expanded Medicaid. That's where we are today. I want to share with you a brief personal story, personal health story. Now, there may be some HIPAA folks in here that might get upset about this, but I just want you to know this is my personal health information, and so I'm willingly disclosing it. It was about that same time frame, 2006, I went in for a routine physical. By the way, at that time, I'll share my age here, I believe I was 48. Went in for a routine physical. If there's any physicians in the room, you know what I'm talking about here. For males, you're always going to get what's called a digital rectal exam, which is where the doctor actually feels your prostate to see if there's any irregularities on your prostate, because we men are prone to prostate cancer. But as part of that, they also do what's called an occult blood test, stool test. It's part of that exam. I know I'm getting a little crazy here, but I think this is important. So in that office that day, my physician conducts that test. And all they do is apply a little of that on a little card. They put some solution on it, and it comes back blue. That means there's blood. That's not terribly unusual, I'm told, for females, but it's extremely unusual for males. It indicates something's going on. So my doctor says, this is probably nothing, Gerard, but you really ought to go in and have a colonoscopy. Everybody knows what that is, certainly those over 50 where it's recommended. And it's probably nothing. So I go in and have this colonoscopy. And when my GI comes out and you're, kind of starry-eyed, waking up, I could tell there was concern on his face. And he said, well, I got good news and bad news. The polyp that you presented with as part of the exam, I don't think it's anything to worry about, but there's another one that I'm concerned about. And the next day they called me and said, well, I got good news. I was right. The one that I was worried about is benign. The other one has cancer in the tip of the polyp. And this is kind of typical of medicine because it's not an exact science, as any physicians in the room know. That's why they call it the practice of medicine, right, Dr. Wilbur? So my physician says, based on the margins in this polyp, I think you're good to go. No further treatment needed. The next day, I get a call where he tells me that it's custom procedure to discuss it with his colleagues. And half come back and say, have surgery, and the other half say, don't. And I called my primary care physician, and I said, I'm leaning towards having the surgery. He said, you're crazy. That surgery is brutal. And so I did that, and I was in the hospital for 7 days. Back then, the procedure was a lot more morbid than it is today. There's been some advances in that respect. The good news here is that I had part of my colon removed, but my lymph nodes were negative. No further treatment needed. I have been on a regimen. It was every year for a few years, and I went to the every 5-year program, and I've produced one BB-sized polyp since then in 18 years, 17 years, and that was in September of my last exam. No big deal, come back 3 years. Here's the reason I'm sharing this. There's no substitute for wellness care with respect to dealing with future bad situations is one way to put it. What my physician told me, actually my GI told me, was that 9 months later, I probably wouldn't be standing here. That polyp would have pushed through the colon wall. I know I'm getting a little grotesque here. And I know the doctors know this, and then it gets in your lymph nodes, and then it's really a bad situation. So I'm just thinking about how many people in our state and in our country don't have that simple access to that simple test. And I know, Dr. Woodward, I've heard so many of my physician friends that I play golf with all the time talk about showing up in the ER with a 500 blood sugar. Does that happen? Every day. And often the results, amputation. Happens a lot. Your limb is entered necrosis, whatever, and it's a problem. So when you think about addressing the healthcare issue, there's health, and then there's health care. And health care is different than health. Health care is provided by humans. I don't happen to believe, this is where I may differ from some people on the left, that anybody has the right to the work product of someone else. Health care is a work product of humans. Nobody's entitled to that. There was something that was passed in 1986 that grossly complicates dealing with this issue from a financial perspective. Now we're talking about health care. And it's called, for short, all the doctors and the insurance people are well aware of, it's called EMTALA. The Emergency Medical Assistance, what is it, Dr. Woodward? Labor Act. I missed one of them there. But bottom line is, I don't know why all of a sudden I forgot the actual full name of the acronym. But here's the bottom line. If somebody shows up in the emergency room today, have you ever seen a doctor say, hey, look, can you pay for this before I treat you? If somebody showed up in your business, those of us in business, and said, hey, look, will you just give this to me? I can't pay for it. What would you tell them? See you. Out of here. By law, best of my knowledge, the healthcare industry is the only one, those who operate emergency rooms, this is where it applies. They've got to stabilize the patient, but they end up doing a lot more than just stabilize them. And they're not going to let them out until they know they're going to be in good hands. But it's by law the only industry I'm aware of where the government says you've got to provide your service for free. And if you don't, you lose out on operating within certain programs like Medicaid and Medicare. That's by law. You know who signed that into law, don't you? President Ronald Reagan. He advocated for this. That's just a fact. And I'm not here on trying to pitch you on that being a good or a bad law. I'm just telling you that's what we got. And what we have right now is a lot of hospitals in this state every single day that have people showing up in their ERs that have zero insurance and zero way to pay for it. And those hospitals are not saying, I'm not going to treat you until you pay. I don't know of any. And if they do, they get reported, they're getting hauled off to jail. That's what's going to happen probably. So that's kind of where we are today, and that's the situation I think we have to address. And so what that is accounted for in financial presentations and statements for healthcare institutions is what's called uncompensated care. You've been hearing that. You're debating this Medicaid expansion thing. That's behind a lot of it. I think, in my view, in this debate, we're focused on the wrong thing. Again, distinguishing between health and health care is that with respect to health, I don't know anybody that says, well, I don't want people to have good health, to suffer, to even die as a result of disease. I don't know anybody that wishes for that. Here's the fundamental problem, though. We keep inventing more care because we're smart and we're innovative. We keep inventing more care, new procedures, new therapies, new drugs, every single day. That's a good thing. Cures disease, alleviates suffering, enables people to live longer lives. Guess what? Costs money. That's the fundamental problem. If we just quit inventing care, this problem would likely ultimately go away. And I hear a lot of people say, we just need to go back to the way it was in the 50s. Yeah, you just died. Kemp, sorry, we don't have any treatment for that. Think about everything that's been invented since then. Since 2 years ago. Are you familiar with a new treatment for sickle cell anemia? Given our population, where this disease primarily affects the African American population in our state, and our state's demographics are such that we have just under 40% African Americans. Are you familiar with this, Dr. Wilbur? It's brand new. It's a gene therapy treatment. CMS just approved it for Medicaid and Medicare. It's $2.2 million for the treatment. Now, who's going to play God and say, sorry, you can't have that? I remember taking my wife to the ER down the street here at Baptist Hospital about 6 years ago, 11 o'clock on a Tuesday night, suffering from kidney stones. And we're in the ER, and I happened to see a family also in there with a young black girl that was in enormous pain, suffering a sickle cell anemia. I guess it's called an attack. I'm not exactly sure what the term is. But it bothered me watching her suffer in that chair to the point where I went back to the ER, started walking around saying, somebody's got to come help this girl. So if this treatment could alleviate that, just as an example of the fundamental problem in healthcare, which is we keep inventing more of it and it costs money, and guess what? You think the private insurance companies have accounted for this new treatment? Those that have that? No. So what's likely to happen? Premiums go up. If we just had less care, premiums would be lower. That's not going to happen. That's not the way our society works. So who's going to decide who gets what treatment? That's coming, state of Mississippi. This CMS just approved this brand new treatment. That is coming. There's no doubt about it. So back to the issue of Medicaid expansion. My experience with this issue and this topic goes back to 2013. Now, expansion wasn't even available until 2014. 2013, I did a split-screen debate at public television. I was asked by a local policy organization to stand in for that. And it was, the opposing party was a local attorney that was advocating in favor of expansion. I was advocating against it, but it wasn't just brute force, unequivocal, I'm against it. It was, let's think about some other ways to address this problem. And at that point, I suggested block grants. Why don't we go to the federal government and say, get a waiver and say, hey, federal government, why don't you just send us, the state, the money that's currently going in or would go into Medicaid if we added this coverage group, and let us administer it and figure out the eligibility thresholds and the various other eligibility criteria, and just administer it without the federal government having its thumb on every single piece of it. And Drew Snyder and his people at Medicaid, it's a full-time job, just keeping up with the regulations and the mountain of government paperwork related to that. That was what I was suggesting. When I look at those who, and I see both sides of this, and I wrote an article, many of you I know have probably read it, it's long, I apologize for that, but there's a lot to say. And I went into, here's what proponents say, here's what opponents say, and I try to cut to, here's kind of where I think the truth is, my opinion. Having gone to Wall Street and raised a bunch of money to acquire companies, participated in probably 60 different deals, was successful in 6, because it takes about 10 to 15 you work on, and you work hard, and you work long, and you win about 10% of them. That's the way it works. That's brute force capitalism when you're buying companies. The investment bankers can make these companies look way better than they are. That's what they get paid to do. It's a realtor that's dressing up a home to sell. They make those things look way better than they usually are when you show up. Here's what I learned about countless hours reviewing pro forma financial information about sellers of companies with these financial documents produced by their investment bankers and third-party CPA firms. When you always look at projecting out into the future, and that's what this discussion of Medicaid expansion is all about. What does this do to us in the future? From a cost perspective, from a healthcare perspective, from a hospital finance perspective, all about projecting the future. It's extremely difficult to do. My rule of thumb was take the revenue and cut about 20% off of that and take the expenses and add about 20% to that. That's usually where the truth is when you're looking at these companies. And this is similar in that respect. I have had the privilege of interviewing Mayor Carolyn McAdams, the mayor of Greenwood, 3 or 4 times over the last year and a half. Anytime we talk about the dire financial condition of many of the hospitals in the state, usually that revolves around the adjective rural hospital. You would agree with that, wouldn't you? You usually hear it always expressed in the context of the rural hospitals. Greenwood LaFleur is an example of such. And when I'd interview the mayor, who's a delight to interview, but I like to sort of dig into the financial reports of this institution, all of which are available online. I've read them the last 6 years. She can't answer that, and it's unfair on my part to expect her to. And I would ask her, well, can we get somebody that can? I have legitimate questions about it, and unfortunately we weren't able to work that out. Has anybody ever looked at Greenwood LaFleur's financial statements? About $100 million of revenue, $20 million net loss. You think it's only rural hospitals? You were in the room, Luann, when I pointed this out. Gulfport Memorial, $400 million gross revenue, $60 million net loss. Only 8% of their payer mix was Medicaid. About 48% of it was Medicare. Anybody that's in that business knows that reimburses under cost as well. Usually if you get $120 from private insurance, you get around $100 from if you're lucky, from Medicare, and about $85 to $90 from Medicaid. Pretty close? Anybody? Most doctors would tell you I'm getting reimbursed below cost when I'm treating on Medicaid and Medicare. But when you look at Greenwood LaFleur, what the mayor said was, well, 80% of our services are uncompensated. My question was, 80% of the encounters, 80% of the patients, 80% of your cost, 80% of what you would be reimbursed? And she didn't know. And again, no disrespect to the mayor, she wouldn't know that sort of stuff, but it was, I think, a valid question. And nobody's been able to answer that question thus far. It's just 80%. There's no question that the public firm that produced their financial statements, I think they're accurate. I mean, they're on the hook for that, coming from that world. But when you hear the proponents of Medicaid expansion say, hey, this will fix this hospital financial problem, I don't know. That's the problem I have with it. And my suggestion was, could we take a Greenwood LaFleur or any of these other hospitals, let's take their last 3 years' financial statements, and let's assume that Medicaid had been expanded, and plug that in and produce a pro forma of that. That would make the case for that. Now, I know that may be difficult, the information to ascertain that, because you'd have to know the income of the patients. But you definitely, I think, could do some cross-checking to get close on that. Seems like that makes sense. I hear opponents say, well, look at the other states that expanded. They've got hospitals that are failing. That's absolutely true, because it's a problem that's way beyond just Medicaid expansion. State of California, if you read my article, I did the research on that, they report that half of their hospitals, are losing money. Half. They ain't rural California. 1 in 5, they say, is on the verge of closing. The renowned Cleveland Clinic, anybody ever heard of them? Pretty prominent healthcare institution. They only lost $1.2 billion last year. They're not rural. It's not just a rural problem. It's more fundamental than that. It's more sweeping than that. So you got to take that off the table. I hear this. Well, they just need to reconfigure. They got too much admin costs. Their buildings are too expensive. It's not really current relative to modern medicine. Well, I agree with that. But there's no amount of re-engineering and reconfiguring and restructuring and reorganizing that can offset free. Nobody sits down to do a business plan and says, well, I'm going to plug in a certain amount of free in my revenue. Hospitals do. So the focus should be on how do we eliminate that problem. That's from the health care perspective. From the health perspective, it's how do people like Gerard have access to a simple blood test to determine that they may have colon cancer so they can live? That's what it's all about. And that's what I hope you guys can maybe coalesce around. There's an economic aspect of this, that's health care, and there's a health aspect. My friend Dr. Edney, every time he comes on the program, he is a great advocate for health in the state of Mississippi and health outcomes. Is it guaranteed that if we expand Medicaid, that fixes that? Probably not. But does it improve it? It seems rational to me. If it doesn't, then we ought to get rid of the whole Medicaid program because it worsens health outcomes. That doesn't make any sense either. So somewhere in the middle is probably the truth. So I'm going to share a story before I sit down here that was shared to me by my friend Dr. Luann Woodward in the city seated here. If you don't know Dr. Woodward, she is the Vice Chancellor of the University of Mississippi Medical Center. And she told me about a patient that presented, oh, by the way, she's an ER doctor, right, by her practice specialty. And she told me that even though she serves as the Vice Chancellor, that she will, from time to time, put her coat on and go make some rounds in the ER just to kind of stay current on what all that looks like. And she told me a story about a patient that presented. If I don't get this right, Dr. Wilbur, please correct me. I hope so. And she said that she walked in the room, and this patient presented with a protrusion, with fluid in the neck. And I think in her professional opinion at that point, she knew something bad was probably going on. And she said, trying to use her best bedside manner, said, gee, what brought you here today? And the patient pointed to that lesion on the outside there of the neck. I see that. I'll fast forward. Then she said, why today? This has been going on for a while. Clearly, it just didn't pop up this morning. I believe what he said was, I finally got a ride. Is that right? I finally got a ride. I don't know what the solution to that is, and I'm not sitting here saying I got it, but that's not right. You don't have a human bone in your body if you don't feel some degree of compassion for that. I believe I can be a conservative and have compassion. I believe that's consistent with being conservative. Whether or not Medicaid expansion is the answer to that, that's something you guys got to hash out. I have provided some suggestions in my article of alternatives. Fundamentally, I oppose the expansion of government. And honestly, if we're going to pull down $1.5 billion from the federal government, you're watching our finances. We don't have it. We're running $2 trillion deficits. We have $34 trillion in debt. This just adds to it. So that's a difficult thing. But we did just pull down $750 million from the federal government to enhance our payment reforms in the traditional Medicaid program. I think that was a great idea. I think it made sense. That was an effort to try to get some more money to these hospitals that are taking care. So right now what we're saying is, hey, hospitals, you got to take care of all these people, but we're not going to let you get paid for it. That's what's happening. Whether expansion is the solution to that or not, I don't think unto itself it is, but that's exactly what's happening today. I know there's folks in here that represent hospitals that may have a different take on that, but I've talked to a bunch of them as well. I play golf every weekend with a guy that runs the Merits in the state of Mississippi. I believe that's the largest hospital operation in the state in terms of number of hospitals. And for 4 hours while we're walking, I pick his brain and get him to tell me about all. He told me the other day about somebody in the hospital It's been there 11 and a half months. Was cured about 7 months ago and released, tied up in all sorts of legal battles. So literally, they're feeding him and taking care and housing this person in the hospital. I believe we have some of those at UMC, do we not, Dr. Wilbur? It's not health care, but that's what's happening. We're paying for it, no matter what. So we got a lot of smart people in this room right now. Surely we can get creative and come up with something to address this issue. I witnessed the presentation yesterday, Representative McGee's committee held yesterday with the Hilltop. I had read that report 2 years ago when they published it, and it got into the details of the economics of Medicaid expansion. I'll just be perfectly honest, it made a compelling case from an economic perspective. But I would also tell you, relying on my business instincts, most of the time when you're looking at data projected out 5 or 6 years, you just got to temper it a little bit. All things don't always work out that way. All aspects of that. We don't really know how many people would enroll. We can guess, we have some idea. There's concerns by conservatives that oppose this that say, well, all these people that presently have employer-based coverage in the group market that would be eligible for Medicaid based on their income would drop their group coverage and they go to Medicaid. That's a legitimate concern. How many? Does anybody know? Can anybody answer the question of all the employers in the state of Mississippi? How many employees work for them that are enrolled in their group coverage whose income is less than 138% of the federal poverty level? Thus, they would qualify for Medicaid? What's that number? You need to know the total risk if that's the case, because that means the hospitals and the providers are going to get reimbursed less under Medicaid, and the state's portion is going to be higher. What is that number? How many employers in the state of Mississippi are paying the ACA penalties because they don't provide affordable coverage as defined by the ACA? And that only applies to employers over 50. How many work for employers under 50 that make less than 138% of the federal poverty level? Therefore, they're not on any employer group coverage. We need those answers to me to make this informed decision. There's lots of other data points associated with that as well. There's people that say, well, people that are enrolled in the ACA exchanges that would qualify for Medicaid would leave the ACA, and by law, when they have to re-enroll, the government makes them go to Medicaid because it costs them less money than being in the ACA and receiving the subsidies. You know how many that is, the total number? 24,000 in the state of Mississippi. 183,000 are enrolled in the ACA. 24,000 have an income between 100 and 150% of the federal poverty level. If every single one of them went and enrolled in the Medicaid program, yeah, that's probably not anticipated in the projections of the number, the 200 to 230,000 number. So it's total 24,000 if every single one of them went that way. The ACA exchanges could be leveraged as a way to cover. This is the Arkansas Works program did that. They got a waiver. They pulled down Medicaid money. They enrolled people in the exchanges, but you still have an out-of-pocket component. It can be limited to $3,450 based on cost-sharing reductions, which is a provision of the Affordable Care Act. Maybe you could get Medicaid dollars to cover the out-of-pocket costs. Since premiums are now free, that was all implemented in the American Rescue Plan, made more permanent in the Inflation Reduction Act. So every time you hear the president talk about Republicans want to tear down the Inflation Reduction Act and they want you to lose your health care, by the way, that's what he's talking about. He's talking about the American Rescue Plan, which temporarily enhanced the subsidies in the ACA and were made more permanent in the Inflation Reduction Act. That's what he's talking about. Most people don't really focus on that as part of that law, which is named inappropriately in my view. So there, again, that's why I wrote this article saying, think about some out-of-the-box ways. If I, as an employer, could somehow adopt families and put them on my group coverage, I'd be willing to do that. I floated that idea to my lawyer 10 years ago, and he started getting my head hurt with all this ERISA stuff, and, you know, the insurers don't like that, but I was just trying to help. Surely we could come up with some other solutions to try to defray the cost of this, and again, with the goal of achieving this universal coverage so that folks have access to health care and the people providing it aren't doing it for free. And that's what's happening right now. to a great extent. Thank you so much for having me today, and thanks for your time and attention.
Thank you, Mr. Gilbert, for that professional and personal testimony on healthcare. We'll have questions now. Senator Bryan, you good? Questions from the committee? That's pretty good. Let's pause for a commercial break now. Thank you very much, Gerard, for coming.
Thank you.
Always.
Thank you.
All right, next we got Dr. Kim Hoover, who currently serves as the interim president and CEO and COO for the Mississippi Hospital Association, for her presentation.
I appreciate that. I didn't mean to unseat the celebrity, and I'm not sure this is the best lineup when you follow the celebrity, but I'm going to do that anyway. So, Chairman, thank you for inviting me today, and I want to talk a little bit about healthcare coverage expansion. I'm certainly not going to attempt to debunk all of the things that have been said. I did read the article, and it is lengthy, but it does have a lot of information in it. So I'm here as the interim CEO and president for the Mississippi Hospital Association. I want to talk a little bit about just proposals for healthcare coverage. And again, we'll not be debating the nuances between health and healthcare. So, just as Mr. Gilbert said, we are one of 10 states that has not expanded Medicaid. You can see that it is basically states that are in the South. There are a couple that have not. If you think about Wisconsin, for example, they have, years ago, they created a program that really took care of this issue, so it probably will not happen there. We do know that Alabama and Georgia are talking right now. Georgia's governor has indicated that the language that has been proposed for the last couple of years needs to stay, so we're not sure if that's going to go through. So just to take you back then to what is low income and who is eligible. If you'll have to excuse me, I've got to put my glasses on now. I'm not going to reveal my exact age, but you're going to know here in just a minute. So low income is really defined as those adults in household earnings that have up to 138% of the federal poverty level. So for a single adult household, that really runs out to about $2,000, a little bit over $20,000 a year. And adults in a four-person household, that bumps up to about $34,000 for 138%, up to around $34,000 for four people in a household. Now, we know that our Mississippi median income in 2022 was just almost $53,000. So you can see that the median income for Mississippi households, if you take a look at what it is, how many are in poverty in Mississippi, that's a lot higher than those that we consider low income. And there are about 20% of Mississippians who are in poverty. I'm just making sure that's going through. So what then would be the fundamental goals? What are we really trying to do with increasing health care coverage for Mississippians? Well, obviously, we want to make sure that there's coverage for low-income working Mississippians, and I'm going to get into a little bit about how those people stay healthy and stay working. We want to improve the health of our working Mississippians, and in doing that, we believe that we can increase the labor participation. And I'll give some examples of that. We can also improve our workplace training. We can improve some of the education opportunities through this. We can create an opportunity to transition off of Medicaid dependence, and we can do that if we can get people more into the labor force, more full-time over part-time, and moving up into positions and having greater earnings. And then finally, in this particular slide, it's fiscally responsible in terms of what it does for Mississippi and saving money. So So if we continue on, you see that Mississippi has some opportunity right now to do some innovative things. And in fact, Mr. Gibbert just mentioned some things that you might be able to use Medicaid dollars for. And so it gives us a chance to really take a look and say, all right, we're not going to do something that's been done in every state. Instead, we're going to see what is unique to Mississippi and what we can provide that's going to be unique to our population. And so an example of that, which has been brought up before, and that was when this was proposed in 2019, is a public-private partnership to improve health care. We can incentivize accountability really in the plans. We can incentivize that in the participants. We've called that skin in the game, and we can do that through a number of ways, which I'll talk about. Improving access to mental and behavioral health care is really a big deal right now, and it's a big issue. If you think about over the past few years, what kind of increase that we have seen in opioid use, misuse, and abuse that really has created a dent in productivity in our workplace. There are other issues like homelessness and things like that that you hear about. We hear about jail time for behavioral health issues. But in particular, opioid use, misuse, and abuse has caused some issues. So being able to access health care around mental health is important. And then improving health care to preventive care. Again, Mr. Gibbert's example of screening for colon cancer. If we think about the sort of that necessary what we all do when we go in to see a primary care doctor, for example. So if we go in to see a primary care doctor, we get screened for things like diabetes, you get your glucose checked, you get your blood pressure checked. But now, instead of getting your glucose, your blood sugar checked, and someone saying, you know what, you're up to 150 or 160, and so I think you're probably going to end up being diabetic, or 200 or 300. They are really checking, physicians are checking at a much lower level now, because we have evidence that if we can identify pre-diabetics before they become diabetics, we have an opportunity to possibly ward that off and or do what we know we can do to save eyesight, to save limbs, to save lives. And so if you've got someone who has lost a limb, someone who has lost eyesight, someone who is battling diabetes, a fluctuating blood sugar all day long, they are not going to be able to be a productive member of our workforce. And so if we think about another issue, and that is healthcare workforce recruitment. And so many of us know that we often have difficulty recruiting physicians. We know that the number of self-employed physicians in Mississippi is much lower than it was before. And so we do need to be able to recruit physicians. We need to be able to recruit nurses. COVID has shown us that now it's not just physicians and nurses, it's lab techs, it's med techs, it's x-ray, it's our basic workers in all parts of the hospitals and other healthcare facilities. And to do that, we need to be able to not only recruit them in with the appropriate salaries. I mean, there's a lot to unpack around hospital workforce, but the truth is when salaries went up during COVID, they began to stabilize as COVID began to stabilize, but they're not going to go back down to pre-pandemic levels. And so we're going to be dealing with this issue for a while. And so as more and more physicians and nurses reach retirement age, we're also going to be seeing them exit and needing more. We export, certainly know we export nurses, and we export some physicians and other healthcare workers as well. What we'd like to be able to do is not export. We'd like to be able to keep the ones that we educate in the state of Mississippi, and then we'd also like to get some of those back who've gone. We'd like to take some of those who've now gone off to get experience and bring them back into the state of Mississippi. So So just to bring up a little bit about the research here, the Kaiser Family Foundation actually looked at over 300 articles that were written and some studies that were done, and they did this in 2019. And what they found was that, in fact, expanded healthcare coverage does increase health coverage, it does increase affordability, and it does increase access to care. The budget savings, there were budget savings for states because there was enhanced federal match with that. It did reduce uncompensated care costs for hospitals, and I don't have the exact amount of that, but he'll be asking me that next probably. So, and it increases the ability, it increases the diagnosis and early diagnosis of things like cancer, chronic conditions like diabetes, chronic conditions like cardiovascular disease. And so I'll bring up just another example of early diagnosis. If you think about, for example, if some of you have possibly been to a dialysis center, it might surprise you if you go to a dialysis center how many young African American men you see being dialyzed because they are in kidney failure. Young men who, if they had not had uncontrolled hypertension, they would not be sitting in a dialysis chair, potentially waiting on a kidney transplant, and they will probably not be part of the workforce. So those are the kinds of people that we would want to bring into, people who have a number of working years ahead of them. And I will say, I do want to, as we talk about, I didn't go through the last one here, we look at the increased availability of primary care appointments, but some have found that there were longer wait times. You know, to your credit, to the governor, to the legislature, the efforts of UMC, William Carey, and others, we have in fact grown our physician workforce. And so that is something that hopefully we can continue to grow and make sure people can get primary care. So why support increasing coverage? Well, it's the right thing to do to help Mississippians who don't have health insurance. It also puts Mississippi federal taxes back in Mississippi. It helps us improve our healthcare infrastructure. Right now, we talked about physicians and nurses and other healthcare providers not only shoring up our staffing, but if you think about the recruitment, but the technology, our facilities that are getting older, and those things that need to be updated, the equipment, that's important for us too to be able to provide care. And of course, there are economic benefits for all of Mississippi, again, that I'll talk about in just a moment. So, I just wanted to give you a couple of options in addition to the last one that I'll talk about, which will be no surprise to you probably. So the first one is just flat out Medicaid expansion. Let's just take what was provided for under the ACA and let's just do Medicaid expansion like others have done Medicaid expansion. We could also think about state-only options where we had with or without federal matching funds. I've got some examples of that. And then we could also think about that federal waiver to tailor an expansion program that is much more specific to Mississippi needs. And that's where we'll talk about the Mississippi Cares proposal that was presented in 2019 with just a couple of caveats with that. So the first one around Medicaid expansion, that's literally just covering those non-disabled adults who are earning 138% of the federal poverty level. There's a federal match rate of 90%, so that's the 90-10 match. And then there's one caveat in here that was not present until fairly recently, and that is that the federal government has given another incentive, and that is the federal match rate increase of 5% for the traditional population for 2 years. All right, so it's not the population that would go on, the new population that would come in, but these are the ones who are already on traditional Medicaid. So So state-only options, with or without federal funding, you could think about something like a high-risk pool with a low buy-in. You could allow buy-in to the state and school employees' health insurance plan. You might provide vouchers for, both of these would be state subsidized, for getting coverage on an open market, that's something similar to the federal exchange, or helping to pay for high deductibles, because I do know a lot of people, particularly some of those who are self-employed. My brothers are farmers and their deductibles are, $12,000 and $15,000 for their insurance. That can be devastating for some families. And then looking at creating a state marketplace option that it would be tailored to Mississippi. And then the one that obviously I want to talk more specifically about is MHA's Mississippi Cares proposal. That was from 2019. So in this one, Medicaid applies for the 1115 waiver. The plan members would be enrolled in a health plan. There could be either a set premium or there could be a sliding scale premium for the plan members. There would be higher copays. There could be, there could be, for example, higher copays when someone goes into an emergency department and it's an unnecessary visit. And then hospital taxes are actually offsetting the state share cost, and that's important. So if we think about what was in that plan, and this one happened to be modeled off of the Healthy Indiana plan, Pence's plan, there were work requirements, community engagement, education. There are, the health plans would provide workplace training and education options. There were quality measures on outcomes. And so that's a form of accountability, just like hospitals are held to, from the Division of Medicaid, the QUIP plan, which is the Quality Incentive Program. Other plans could be held to that same level of accountability. And then the skin in the game for the plan members, we've already talked about the potential for a premium. Hospitals obviously are going to be paying taxes. They're going to have a lot of skin in the game. And then the providers, and thinking about that quality outcomes and the measures that they would have. And the other piece that was not there in 2019 was the 5% increase, enhanced FMAP for that traditional Medicaid population. So just a graphic to show you how that would look. Obviously, the legislature, would describe its plan for increasing coverage. Thank you, don't let me pull that down. The Division of Medicaid would request that 1115 demonstration waiver because this would be like a pilot project. You got two outcomes here. That waiver describes those program goals, and CMS could say, no, we don't approve this, but we're going to come back and we're going to negotiate revisions, or we're going to consider some alternatives. Or CMS could say, yes, we approve this as is. So if that's the case, then you begin to implement where you have the hospitals paying the taxes, the state requests the federal funds, there is a premium tax for newly covered members. That then allows us to take in the Mississippi Cares private-public partnership and enroll new members in the Medicaid MCO plan. But the real kicker here that everyone wants to know about is how do we pay for this? So I've gone out, I've got examples, and I want to go through each one of these. I've got 200,000 members, and I've got 250,000 members. And so I could go out to 300,000 to 350 and keep going off the page here. I think the key is that when you get to a point that there is not, when the state is no longer in positive numbers, you could consider in that waiver request, if we get to this point, then we will no longer be able to, we can cap it. So that's an option to cap the number of people there. So if you look at a 4-year average annual premium cost per member, and this is comparable, the $6,000 is comparable to the state health insurance plan premiums right now. Doesn't matter if you've got 2,000 members or you've got 250,000 members. Then you take an average, the new annual premium payment. All right, so that's the new members that we anticipate with 200,000 and 250,000, and you've got a cost of $1.2 billion and a cost of $1.5 billion. Now, the 10% annual state share needed to fund those premiums, 10%, it's 120 million, and it goes up to 150 if there are 250,000 who actually enroll. Now, there is an existing hospital tax that is already there that could be redirected to take care of the state share, to fund the state share for expansion. All right, so we're plugging that 100 million in there. There would also be a 4% annual premium tax paid by Medicaid MCOs. So right now, health plans pay a tax. All health insurance plans pay a tax, and it goes into the general fund. Now, North Carolina, who most recently expanded Medicaid, did create a medical care fund, and that's where they're putting some of these savings so that they can have that banked in case there is something that they need to use it for. All right, and so we also said, all right, let's just add in a plan member's going to pay $20 a month. All right, we don't have the sliding scale because that would be too difficult to put in here. So we've got our hospital tax, we've got our new MCO premium tax, we've got our plan member, what they actually put in, and then we're going to minus the 10% state share, and then that's going to equal our annual net. All right, so if we've got 168 million versus 162 million, 168 million for the 200,000, 162 million for the 250. Obviously, the more people who enroll, then you've got more of those $6,000 premiums that you've got to cover there. So the direct state impact, remembering we've got a 5% increase on traditional Medicaid patients right now, that's going to be about $300 million per year. All right, so over the 2 years that we're going to be able to get it, we're looking at 700 million additional coming in with traditional Medicaid. So if we add our year one annual net and year two annual net, we end up with 1.036 billion versus 1.024 billion for the 200 members versus 250,000 members. So if you take that direct state impact, now remember years 3 and 4 does not have the 700 million, no 350 million a year. So now we've reduced that down to 336 million and 324 million. Then the total 4-year direct state impact is 1.37 billion, or slightly less with 250 million at $1.35 billion. And so when we talk about the potential for money to come into the state, into the plan, if in fact we can take something like this and create something that is specific for Mississippi, that works, that we can scale out, we have the potential for some real reform for Medicaid in the state of Mississippi as well. All right, so with that, I think I stayed within my 10 minutes. I'm not sure I did. We are a little behind there, but I'm happy to take questions.
Thank you very much, Dr. Hoover. The 200 members and 250,000 members, is that obviously your projection, and you mentioned exceeding that?
Well, so I know you've read that some states have said they projected maybe 200,000 and 400 or 500,000 actually enrolled. And that could be for some of the things that Mr. Gibbert was talking about, people drop off of certain things. In this case, I know the number that was presented yesterday was 18,000. We had actually anticipated in 2019 that it would be between 200 and 300,000. So we were going in between those numbers and then what was presented in the Medicaid presentation. If you carry this out, which is why you can think about capping the participant numbers. If you carry that out, if someone says, well, I want to see what it looks like at 500,000 members, if we're going to just take it to the extreme, we can certainly do that. I didn't have room on the slide.
Questions?
Wait, no, you first.
Lady from Jones?
Yeah, listen, I'm I'm trying to keep up. Now, yesterday they said about 233,000 was the number that they thought that it would be. But now we have gone through a Medicaid expansion during the COVID epidemic. And I believe the Medicaid gave us some numbers on that. Why is it that you all can't tell us how many people exactly, once we get to the peak number, did that go up to 500,000? Did we go up to 500,000 during that time when we had Medicaid expansion and people could participate in the program?
So I don't know about that. It's a good question. I know that disenrollment is occurring now, and so people are, beginning to come off of that. I don't have those exact numbers, and we have. This was in 2019 when we originally did this. And so to be able to pull this back together again, we potentially would be doing more research and adding more to that.
Well, Drew Snyder said that it was 100,000, and it was reported in the news, and he indicated that there would be 35 more thousand. But let me ask you this. You can't tell us from where we've had a dry run, because we had a dry run during the COVID. The people who did not have insurance could get on Medicaid up to 138%. Can you tell us whether there was a problem with doctors refusing to care for those people at the peak time?
I do not know about that because it was COVID. It was a very unique situation. Medicaid would have the exact numbers, by the way, of everyone who actually came in on that time. Now, whether or not there is, it was an extenuating circumstance. Just because it was COVID and some people sought care and some people did not seek care. But Medicaid, Mr. Snyder would have the exact numbers of those who signed in.
And then my last question to you, with this chart that you have here, that you've explained what your proposal would be. When we look at what the Corey Miller presented, he shows that with just traditional Medicaid, with the ACA rollout, that it's 1.3 billion, and you're at 1.3 billion with all kinds of taxes and everything else. Can you tell me why you think your program is better than what Corey Miller has presented to us, when we don't have to raise taxes, we don't have to put premiums for people, we don't have to do any of those things.
All right, so I didn't hear what was presented, but this one doesn't cost the state anything. So the traditional ACA is a 10% match by the state.
Well, and I'm through, but the testimony was, and in Hilltop and with the state economist, that the state economist said that on a 3-year conservative projection that the state would not spend any more than what the federal government they would draw down. Hilltop said that it would be 4 years that there would not be any monies that the state would draw down. So I guess, again, you're putting an additional tax on the hospitals. Well,
It's not additional. That tax is
I know you
already.
got an existing tax, but didn't you say you had another tax?
No, that existing tax is the actual. That's on the health insurance plans, the managed care companies, and they're already being taxed. This would be an increase, and I don't have the specifics of what their plans are, where they got their numbers, and that sort of thing.
Thank you.
You're welcome.
That was included in the article yesterday. I did too.
He can't do that, Mr. Chairman.
Well, I'm just trying.
He just
All
can't
right, we'll finish with Mr. Hoover, and then we'll give Mr. Gibbard another shot. Other questions? Gentleman from DeSoto.
Thank you, Mr. Chairman. I just had a couple questions. The Medicare provider tax or the hospital assessment fee that would cover the state's portion for expanding Medicaid, what guarantees would there be that the hospital association or all the member hospitals would be willing to do that forever, ad infinitum? I mean, to bring it online, yeah, but then what is the risk to the state that you guys may dial it back and then we're left holding the bag, so to speak?
So that tax has been around for about 15 years, and it's just been paid. It was a tax that, it's my understanding, just historically, that Medicaid was going to have to make drastic cuts to their budget, and the hospitals were willing to try to assist with that, and did via a hospital tax, and it was never walked back.
Well, is it? And I'm trying to get a firm grasp on
Sure.
this. Is it not really like kind of giving you guys a blank check as long as you're willing to pony up? It just, because there's no limits on how much gets spent if you're providing the match, right? Or the portion that requires the match?
I'm not sure I understand your question. Say that again?
So if you're going to pick up the state's portion through this funding model,
Yes.
and the federal government's going to come in and they're going to give us their match.
They're going
right?
to give Medicaid the match,
The
yes.
Medicaid match. Where's the ceiling on that? Because you can always continue to put in more.
Well,
receive more,
it would
could
be
you
the
not?
participants. We only have so many people in the state.
Okay. Well, what I'm wondering is
That meet
that,
eligibility.
right, what I'm wondering is that, I lost the other question.
That was what I intended. No, I'm kidding.
Yeah.
Sorry.
But, well, just the idea that, you know, when you take, and I guess what I want to hear is there a state, because everywhere I've read, when we put out projections, Gerard was right, you know, projections are just that, they're projections. We say, well, we think it's going to be 150,000, but almost every state that I'm aware of made a projection, and within a few years, it far exceeded their projection.
So that's why you have the ability, if in fact you do this through a waiver, and you're able to develop this, if you develop this plan according to what the state says, this is what I want, you can cap the number of participants. If you said, I don't ever want this to rise to 500, and I don't know that it would, but there are, there are guardrails to put in that you can.
Well, I know that when a state expands, work participation always, it's like an X, the scale. So if we set it at a level of the poverty level, and you have people not participating in the workforce, although we have workforce requirements, they're going to still qualify, are they not, if their income level drops to poverty because they've got coverage?
So that would be assuming everyone who is working for lower wages doesn't want to work. And, I would argue that there are a lot of people, and probably some that I've worked with before in state organizations that did not make that amount of money and were working other jobs. And so it wasn't that they didn't want to work, they just couldn't make enough money to do some of these things. And I think that's the key to whether or not you fundamentally believe that there are working Mississippians who cannot afford health care coverage, who don't get care, who otherwise would get care and be healthier and be able to contribute in a much, even, and it might be, it could be a person whose parents are on Medicaid and can't keep them in insurance, and so they're trying to go to college and rack up debt. I mean, I can think of scenarios, but I can think of the other ones too. I just don't know. That would just be fundamentally what you believe about people.
Okay, thank you.
Dr. Hoover, you mentioned this would be an incentive for workforce participation. Have you seen that in other states as workforce participation improved?
So there's one thing about this. Obviously, this was developed during the Trump CMS, what was being approved during that administration, all right? So there have been some restrictions that have been put in since then. Their work participation in Louisiana has improved. the state of Mississippi has gone from 62.5 in 2000 to 53%, I believe, in 2023. And so we have seen a pretty precipitous drop in workforce participation. I don't have all of the numbers on that, but Louisiana has seen an increase.
And we've heard Dr. Edney speak on preventative health care, and even Mr. Gilbert's testimony alluded to that. So in other states, have we seen where that's improved the health care we've caught?
So I don't have the exact numbers, but again, the most recent one that I looked at were the Louisiana dashboards, and the numbers that they show for colon cancer screening in the over 100,000, newly diagnosed diabetes over 50,000. There's a number for hypertension, and I can't remember, but yes, those numbers, the kinds of things that I've talked about, they've seen a significant increase in those.
Gentleman from Covington.
Thank you, Mr. Chairman. Has there been an estimate on the number of people who would be eligible for subsidized plan on the exchange, who nonetheless, for whatever reason, haven't applied or haven't gone to the trouble of doing that? Is there any estimate on that?
There probably is. I mean, if you looked at the income levels and then determine how many people were on the exchange, you could at least come up with an estimate of it, I would think, if you could get individual income levels.
My follow-up to that, the reason I was asking, and you probably are not going to know the answer to this, but is what percentage of your uncompensated care comes from those people?
I don't know. I do know there's both uncompensated care and bad debt. So when you've got somebody who has a really high deductible, it's very difficult for them. I mean, they avoid care because they don't want to pay the high deductible, but it is almost impossible for them to do that. I don't have the numbers for those who aren't in the market exchange right now who could be.
Other questions? Yes, sir. Yes, ma'am, Senator.
I don't know if this is on or not, but,
Doesn't sound like it is.
is it on now? Okay. You alluded to the fact that those slides and what you're preparing and talking about work was from during the Trump administration. And from what I'm reading on CMS's website, they're strongly discouraging and not approving any work waivers at this point. And also, I think about 6 weeks ago, I read in Mississippi Today where Mississippi suspended all copays on Medicaid because I guess CMS does not want us to collect copays either. So my question is, why are we even talking about this when we can't implement it? I mean, we're talking like we can do this, but yet CMS is not going to grant any of this, at least under the current administration. It doesn't appear.
So CMS, you're exactly right, CMS is not approving those, and so they're walking that back in some states. There are also other examples of opportunities for work. If you think about community involvement, education that actually gets people to a different level of ability, whether it's vocational or some other type, I mean, there are some opportunities, and there'll be another administration, you know, in a few years.
And just as a follow-up, you mentioned Louisiana's seems to have a better workforce participation now, even though they don't have a work requirement. But I live on the borderline of Louisiana, so I get New Orleans news and I look at what goes on. And I know that it was reported that when Louisiana expanded, they were having an average of 3,000 to 5,000 people a month drop private insurance and go on Medicaid, which was, I guess, an unintended consequence. And then they finally, from what I gather, stopped keeping records at the health department. That's a big concern for Mississippi, to reduce our insurance pool, especially of working age people. And you also had a slide up here about developing a high-risk pool for Mississippi. Mississippi had a high-risk pool. And when Obamacare came along, we dissolved our high-risk pool, and I voted against dissolving our high-risk pool because I knew it was a mistake. So it seems like we're trying to go back to what we used to do that seemed to work for our uninsured patients, and I'm perfectly good with going back to our high-risk pool because I think it worked. But I think right now Indiana's trying to plug $1 billion hole in their Medicaid. And I think in 2019, they were basically asking for a cigarette tax because their hospitals said that they couldn't sustain what they were paying for Medicaid after expansion. So I'm just looking at some other states, and you've admitted here that we don't really truly know what the costs are. That's just estimated. I know in Louisiana, it was 3 times the number of people got on the program that they forecasted. They forecasted 200 and something thousand, they got 600 and something thousand. So it's kind of hard to forecast, and Mississippi's budget is not nearly as big as those other states. I mean, we got a smaller budget, so that's what concerns me. People want to help the people that are working, but when we can't legitimately say that they're going to work and that they're not going to do what they did in Louisiana, I'm extremely concerned.
Gentleman from Marshall.
Thank you, Mr. Chairman, and thank you, Madam Director, for your presentation today. Based on this traditional form that you've shown us today, the last couple of days we've been told about what expanded Medicaid would do, the impact on the state for the next 4 years. My question is, what happens after the 4 years? What would be the impact on the state in conjunction with what will be coming in from the federal level after the 4 years pass?
Well, you mean in terms of what might, whether or not something's taken away or added, or just the state impact?
In terms of the money that would be coming from the federal government, along with what the state will cost the state.
All right, so
Yes.
in other words, is the 90-10, is that going to go away? Or is the 77% that we get for traditional Medicaid, will that go up and will that go down? There's always the possibility, every state is different for that particular match for the traditional. You know, this has been said before, if it goes away, it goes away and there's no more program. I mean, then it just goes away. The legislation doesn't matter.
I guess, but if it stays the same, so the numbers you shown us today will go from now to perpetuity if it stays just like this.
So if it stays the same, now what you have to remember is that what you're looking at is the 336 million, 324 million. Those are after the 5% FMAP increases.
Goes away.
Yeah, so you're looking at possibly banking some of that before, but then you can actually forecast out. Now, when you start forecasting out, and you want to take, if you say, all right, I want to see what it's going to be like with 400,000 and 500,000, you can at least see when the state is no longer in a positive number, what that number would be, given these numbers that I've posted here.
Good, thank you, Mr. Chairman. Now you're back.
Gentleman from Washington.
Thank you, Mr. Chairman, and thank you for having these very informative conversations around this subject matter. However, I have a couple of questions. If the minimum wage would increase and from where it is now to what the national average is, and the number of people who are working part-time, they would move into a different financial bracket. Would you agree?
Yes, I mean, that's a pretty big increase, so yes, they would probably move into a different bracket. I can't
Which then would
guarantee
follow me if you will, which then would lower the number of people who would need access to the Medicaid program.
Anything that raises salaries for the working Mississippian has the opportunity to bring them out of that 138%. Yes.
So it was represented to us by several different organizations and people that the expansion of Medicaid could create up to a possible 10,000 jobs. And so if those jobs were created, they would not be minimum wage jobs, would they?
I do not know that.
Okay.
Sorry.
So a lab tech does not make minimum wage. The only person probably at a hospital that make minimum wage is the janitor and maybe a few CNAs. So let's just hypothetically say, if 8,000 of those people got hired into skill-intensive jobs such as phlebotomists, radiologists, all the techs, the bells and whistles, pharmacy techs, the whole 9 yards, and we increased the nursing pool as well as the doctor pool, would that not create an economic boom which would offset some of the people going into the Medicaid pool? They would have traditional insurance. Would you agree with me?
Anytime 8,000 people are hired at hospitals, it does in fact improve. I mean, that's 8,000 if you're not robbing Peter to pay Paul, if you're not bringing them from another place where they're making that same salary. So I don't know that you need an answer from me.
The reason I'm asking you those questions, because there seems to be some consensus from several of my colleagues that folk gonna stop working just to get on Medicaid. So I don't know where that works in that world. Because if I can make $15, $16, $18, $20 an hour, I'm going to work. So my last question is, would you not agree with me that there is no fix-all solution to this Medicaid problem, that you have to have a consortium of programming in order to fix what we're struggling with because we've lost so much money?
Well, I do think what we've presented is an opportunity to do something different for Mississippi that fits Mississippians. And so that's not just the standard, because we'd like to be able to scale that out to help other people.
All right. Thank you, Mr. Chairman.
Yes, sir. Thank you. Any other questions? Senator Bryan. We're winding up. We'll give Gerardus a chance. Okay. All right. Mr. Gilbert, would you like to address the committee again, please? Thank you, Dr. Hoover.
Yeah, thanks, Representative Creedmoor. I attended the presentation yesterday as well from the Hilltop Institute, and I read their report when they published it 2 years ago. So just as I said, and what Dr. Hoover, I believe, also agreed to, you got two different organizations that are forecasting lots of different data points. It's not perfect. There's no way to be perfect, and it requires a lot of effort just to gather that information. But I heard you say something about already having a dry run. I don't think that's totally accurate with respect to expansion of Medicaid. What happened during the COVID era, and Dr. Hoover is well aware of this, the CARES Act, signed into law by President Trump, it included what's called a continuous enrollment provision. And all that really said was, once a person is enrolled in Medicaid, either newly enrolled or currently enrolled at the time the law was filed, until the public health emergency is declared over, you can't disenroll. In exchange for that, states, we're going to increase the FMAP, 6.2%. We have been experiencing that in the state of Mississippi as well as have the other 49 states since then, except the public health emergency ended last year. And the federal government, the Biden administration, ordered the states, start disenrolling people off your Medicaid rolls. And by the way, your FMAP's going away. That additional 6.2% is going away. So it had nothing to do with 138% of the federal poverty level. It had nothing to do with extending coverage to what we're talking about with respect to Medicaid expansion. It simply required that the states, during the COVID emergency, the theory was they're going to need health care, and we don't want people being disenrolled, as has traditionally been the case under Medicaid, because they're no longer eligible, typically because they make too much money. So the government said, you can't do that. And then they said, the public health emergency is over, now you start disenrolling. Now, the last I checked, and I checked this, the most reputable source I've ever found that writes on this subject, Kaiser Family Foundation, in terms of eligibility redeterminations, the state of Mississippi still has 65% of its Medicaid population yet to be redetermined as eligible. Haven't done that yet. That was what I looked at yesterday. And Kaiser does a great job of tracking that. And also the number being disenrolled. And the fear is there's going to be probably 20 million disenrolled off Medicaid just because they're no longer eligible. has nothing to do with Medicaid expansion, expansion group Mississippi. We're talking about nationwide. The number ballooned to like 90 million on Medicaid. It's kind of hard to believe in a country with 330 million. 90 million on Medicaid. So that disenrollment's going on right. So I just wanted to kind of clear that up a little bit. I don't think we've had a so-called dry run here. We didn't offer coverage to what we're talking about here through Medicaid expansion. The government just said you can't kick anybody off the rolls as long as the health emergency is in effect. The other thing I was going to point out was with respect to the dollar stuff and the economics of this.
Point of order, Mr.
Yeah.
Chairman. Point of order.
Yes, sir.
You did not ask for unanimous consent for him to come back up to the body to speak again. So
I'm okay with him speaking. I'm good with this.
Well, if you don't want me to speak, I'm happy to sit down. That's fine. I'm just trying to provide some information.
I'm just trying to figure out why he gets a rebuttal, because that's not.
I'm not rebutting anything. I'm just providing information.
Go ahead.
So, but the chart that Dr. Hoover put up that shows the financial pluses and minuses, if you will, the amount of inflows and the amount of outflows. The Hilltop analysis did a really good job of presenting that data as well. So, and I was just comparing their analysis. I think that's what you were looking at, if I'm not mistaken, because I know you were on the meeting and what was presented here. It differs a little bit. The premium, the direct revenue is what the Hilltop calls it, from the premium tax, from the insurers that operate the managed care aspect of the Medicaid program. I think those numbers were pretty in line. 38 million, I think we had 100 million here, and they said 38 million. Now, understand this was done in 2021, and what they presented yesterday was done in 2021. But the net of all that is pretty close. I can't remember, Dr. Hoover, but they projected in the first year it'd be a net positive of about 355 million. I think your bottom.
338 million.
Yeah, it's pretty close in that respect. So $17 million difference. The net of, you take into consideration the direct tax from the insurers, the premium tax.
We added in the 700 million.
Yeah, the 5% uplift, the 5 percentage points uplift for the first 2 years, which amounts to, I think they said 650 million, and your figures came up with 700 million. So that's relatively close. But again, you can hash those numbers out all day long and come up with a different figure. But all that was pretty close. Something else that I share concerns with Senator Hill is that the Biden administration said, we're not giving out any more waivers on this work requirement stuff. 13 states got it under the Trump administration. 12 have since been challenged and dropped it. Only one state remains that has a work requirement. It too received that waiver from the Trump administration, and that's the one that the lieutenant governor pointed to. That's Georgia. I got curious and did some research on Georgia's experience with this. Georgia, this is where it gets complicated. Georgia got a waiver that included a work requirement to only cover the population in the coverage gap. The coverage gap are all those whose income is below 100% of the federal poverty level, but too much to be covered under the current Medicaid coverage group of caretakers, which is like 25% of the federal poverty level, which is about $4,000 a year. We have a coverage group right now in the state of Mississippi. That's part of base standard Medicaid. So Georgia said, we're only going to cover the people in the coverage gap, not to the full expansion population of 138%. By the way, you're going to have to work 80 hours a month minimum. I don't even know how you do that and make less than $14,500 a year. That's 100% of the federal poverty level. But you know how many people signed up for it? It's exactly right, 1,300. They estimate they have 500,000 that are eligible for Medicaid expansion with full expansion. So that model is really, and they're being challenged, just like the other states, by a number of consumer groups to say you can't impose work requirements to participate in Medicaid. My personal opinion is you're probably not going to get a waiver as long as Joe Biden's the president. You may get one if we change presidents, but then there'd be a watershed event, and all these other states that previously had one would show up and have another one. I also believe even if that occurred, the state of Mississippi would find themselves in court. consumer groups come out of the woodwork.
All right, thank you very much. Look, we got a lot to consider here, and there's a lot of Mississippi lives at stake. We've got a lot of smart people at the Capitol considering many different formulas, and I appreciate all your time, and we've got a lot of work to do. I'm going to let Senator Bryan conclude this.
Push that button up there, Howard. There you go.
I have no idea. Is this on?
It's on.
Okay. I just wanted to say that I informed the governor's office that we were having this meeting and that they were welcome to have someone come present, and I think they chose not to. At least I never heard back. The question I would have asked, and I'll ask rhetorically, is this. It's clear there are a number of people in Mississippi, a large number of people in Mississippi, who do not have access to health care. They don't have access to health insurance. They're in the gap where they make too much money to be eligible for Medicaid, and not enough money to be eligible for the exchange, among other problems. A lot of states have dramatically reduced the number of people that are uninsured simply by just following the Affordable Care Act as it was enacted. And a bunch of others have gotten some sort of waivers here, yonder, and there. So that's their solution, and the number of uninsured have gone down. And the question I have is, if we've been told for well over a decade now that Medicaid expansion, as it is called, is simply not the answer for Mississippi. There's some thing for Mississippi that's peculiar to Mississippi, and this, that, and the other thing. Well, it's been more than a decade, and nobody's come up with anything. We've cut taxes $1 billion a year, but none of these people that say Medicaid expansion is a bad thing and that's just not the solution have come up with any other solution, and it's been 10 years. So I'm just asking the question rhetorically, if the answer is not Medicaid expansion or some variation on that, is it the case that there's no hope for the people who now are uninsured other than to wait for the income tax cuts to kick in and industry to flock to Mississippi, and then everybody will be employed and they'll all have jobs with insurance, and that's the solution for them? I mean, in the meantime, do they just have to fester? And I'm not really trying to be argumentative, but it seems to me that's the question that we all face. And for more than 10 years, the answer's been, well, sorry, folks, you just have to fester.
All right, we got a lot to consider. Thank y'all very much for being here. Rise and report.
Run for your life.